Okay. Right. You can all see my screen? Yes.
Yes.
Yep. So, hi everyone. I am welcome to the first webinar, with a joint webinar between American and the British Society of Otology, and it's on wellness. And as I explained earlier on, it is very different from the usual webinars and meetings we attend because we always focus on the patient. And but this time the focus is on us. That is basically because we need to look after ourselves so that we can provide a good service, and also your career will be a fruitful one, and also a long healthy career is the basis for achieving happiness in your life. So there are several aspects to this. So we are going to discuss some of those aspects. So before we move on, I'll show you this picture here. This is a chap sitting and meditating in early morning near the banks of the river Ganges. And we can't all be like that. And we have to do our work. And sometimes we have to achieve our wellness and happiness sitting wherever we are. So later on, Martin is with us. He is going to share the secret of mindfulness and how to achieve that. So I am Arun Iyer. I'm the moderator for the session. I'm also the education lead for the British Society of Otology, and I work in University Hospital Monklands, which is in west of Scotland. So west of Scotland, it's a very beautiful area, but it rains a lot. As you can see, we got many waterfalls, and in autumn, the colors can become beautiful. But historically, it's an important place. Not many people know that. This is the old map of the Roman Empire. And if you look at that, the northernmost boundary of the Roman Empire runs through just above Glasgow. And there was a wall called Antonine Wall. And this was occupied by the Romans only for about 30 years. Unfortunately, they just couldn't fight against the Picts, who were very fierce warriors from up north. And these pitfalls are the only one which is remaining along with the remnants of the wall. So I'm showing this because what we are trying to do is avoiding pitfalls in our own career. And so the program for the day, I've just told you the introduction. So the plan will be to do a talk on ergonomics and otology, and that is going to be done by Sujana. And following that, we are going to have a talk on the neck and back pain, how to prevent and achieve recovery by Anand Vijayendran. And then there will be a panel discussion sharing the experiences of all these famous otologists. And I will introduce each of the speakers, but we are lucky to have the president of the American Otological Society, William Slattery, and also the president of the British Society of Otology, Peter Mansfield, along with Martin Stepek. And Martin will then do a theory and practice of mindfulness to achieve de-stress and happiness. So without further ado, I will introduce the first speaker of the day, Sujana Chandrasekharan. She is the immediate past president of the American Otological Society and also the past president of the American Academy of Otolaryngology. She's very well known to almost all of us, and she is the consulting editor of Otolaryngology Clinics of North America, and moreover, a fantastic speaker and a good friend of mine. Welcome, Sujana.
Thank you very much. It's really an honor to represent the American Otological Society here and to be with our friends. So thank you very much for this introduction. I was upside down in the Zoom video for the last half hour, and Google is my friend, and I figured out how to fix that. So if you don't mind, I'm going to share my screen. I'm very excited that it's going to work.
Yes.
All right. So I think when Arun reached out to us and suggested that we talk about wellness, wellness can be physical, it can be mental, it can be spiritual. And one of the things we do, as Arun pointed out very beautifully, is the first thing we do is we don't sit on the banks of the Ganges, and we don't meditate as often or as much as possibly we should, and we don't really pay attention to what's happening to our bodies. And come home tired and aching, and only to start it again tomorrow. So I don't have any disclosures. I will tell you that one thing that I think has helped, especially when access to the ear is difficult, is using new techniques in ear surgery, such as endoscopes and maybe exoscopes. So there was a clinics beautifully written, edited by Manuela Fina, Justin Golub, and Dan Lee a couple of years ago. I strongly recommend it. And I'm just going to put a plug. Every issue of Clinics has a free podcast that you can access and listen to, where I get to interview the guest editors. So let's just spend the next few minutes talking about ergonomics. So ergonomics is a science, and it's the study of people's efficiency in their working environment, which results in ideas that both adapt the people to the environment, but adapt the environment to the people. So you can see that the first fellow is, the chair is too low, every joint is misaligned, the arms are overstretched. The second fellow, the chair is high, the person is tall, but they're stooped over a short reading space. The third one looks a little bit better, but the fourth is really the ideal position, where the lower back is supported, the knees and the ankles are, and the hips are in the correct position, the shoulders, elbows, and wrists and the neck are in good position. So when you work like the person on the right, your body will function well longer than if you're working like any of the three people on the left. So work-related musculoskeletal disorders are in fact very prevalent in surgeons. In open surgery, like abdominal surgery or thoracic surgery, 66 to 94% of surgeons report what's called WRMD. In conventional laparoscopic surgery, 73 to 100%. In robot-assisted surgery, where you're kind of hunched over that console, perhaps removing that person's T2 oropharyngeal lesion, 23 to 80% report work-related injuries. So what are the risk factors? We wear heavy things on our heads, loops, headlamps. We have microscopes, and many of us don't take the time for the few seconds that it takes to adjust the microscope so that our neck is in a good position relative to our head and our shoulders. In the table and the monitor position, if you're hyperextended, that's a problem. If the instrument is too long and you're not balanced correctly to use it, surgeon work-related injuries often result in disability, but are usually underreported to institutions. We take a long time to become the surgeon we want to become, and we really don't want our careers cut short. What happens in otolaryngology? A survey of otolaryngologists in the United Kingdom about 20 years ago showed that 72% had back or neck pain, with otology having the highest prevalence. And I will tell you, I wake up every single day with some back and neck pain. So perhaps that number is underreported. Another 377 otolaryngologists in North America, about 5-6 years ago, again, about 64% reported work-related musculoskeletal symptoms. And in a rhinology study, 77% of people reported physical discomfort or symptoms associated with endoscopic sinus surgery, which was supposed to make things better in terms of visibility, less blood loss, etc., for the surgeon and the patient. And then there's this concept of adapting a microscope to level the playing field, literally, between a very tall surgeon and a very short assistant, or vice versa. So I was looking into this, and veterinarians do a lot of what otologists do, sort of fine movements where they're hunched over a bit, small little working spaces. They have to, sort of be on the clock and be quick. And obviously the red is the highest pain prevalence, and then the blue is the lowest pain prevalence. So in the dominant hand, your thumb, your thenar eminence, your wrist has the highest pain prevalence. In the neck and the shoulders, it's the neck, the shoulders, and the trunk have a lot of pain prevalence when you're operating in this manner. So there are really excellent data looking at ergonomic risk when we operate, and we would like our head and body and extremity position to be in the blue, which is the low risk, or sorry, the green, which is the low risk, as opposed to the moderate, which is blue, the high, which is yellow, and then the very high, which is the orange. And if you think about how you position your head, neck, and arms when you operate, you can see for yourself at what risk category you're putting yourself on a day-to-day basis. And this can be in the operating room, this can be in the exam room, trying to examine somebody under a microscope, trying to manipulate instruments over perhaps a very big shoulder that you have to sort of hyperextend your shoulder to get past that, to get into the ear. So Duke Surgery did a program where they put sensors to try to improve surgeon health. And what they say is maintaining your neck flexion at less than or equal to 25 degrees really prevents spine and neck strain during long stints in the operating room. And you know, long stints is defined as only maybe over an hour or two. You don't have to be operating for 8 or 10 hours for this to be considered a strain on your neck. So I talked about how endoscopes were designed to help sinus surgeons from peering down. This is a sort of a graphic of how we've gone from approaching the sphenoid through the nose, hunched over the patient, up to standing up and doing with an endoscope and a monitor. So I don't know if any of you remember these headlights. I certainly do. Trying to figure out how to put the light in and see and carry this heavy weight on your head was difficult and challenging. There was a lot of bleeding, I remember. I remember feeling very stressed when I began my residency in otolaryngology. And within a year or two of my training, endoscopes were introduced, and this was magical. All the things my professors were talking about, I could actually see, but we still didn't know how to do it right. You can see the person on the left here is hyperextending their neck. You can see that this endoscope is very, very heavy, and the person holding it has sort of a wrong grip on it. Here you can see that this person who's operating has a direct view, but this person has craned their neck. And their right side of their neck is really going to hurt at the end of the day. So it's not just enough to adapt the equipment to the person. We have to adapt ourselves to the equipment so that we can maintain a long career. There's also this Goldilocks phenomenon, right? This bed is too hard, this bed is too soft, and this bed is just right. Well, so one size does not fit all. This happens to be my friend Bruce Davidson, who's the chair at Georgetown University, and he is 6'5". And, you know, I'm 5'4¼ on a really good day. So if you turn that into meters, it's something else. I don't know. I don't know. I can't do math. But look at how they are looking at this person's neck, with Bruce being, you know, practically, you know, looks like a number 7, and everyone else also uncomfortable. One option when I was in training and I operated with very tall people and we were standing was to put me on 1 or 2 footstools. And the problem with that is my center of gravity was then very little. You couldn't rock, you had to basically stabilize your lower back, legs and feet in one position. And then if you had to press on the foot pedal for something, you had to somehow get off of the step stool, step on the pedal, get back on the step stool. Very, very awkward scenario. In addition, the most common male glove size is 7.5. and the most common female glove size is 6. And these somewhat terribly unattractive hands that you see there are mine. I'm a size 6.5, and an anesthesiologist who's a 7.5. And I just want to show you the vast difference between those sizes and how that can affect the way men and women interact with equipment. Because if it's hard to grasp, I'm putting much more strain on my hypothenar eminence. I'm putting much more strain on my wrist. I'm giving myself arthritis here, which I may not need to do. So there was a national survey that got published this summer looking at 1,000 otolaryngologists, 30% were women. 85% of women surgeons reported ergonomic issues related directly to instrument design. Difficulty handling instruments like a Wheatlander retractor, for example. It's very hard to close from across the table if you're trying to do an ear surgery and clamp it like this, and often that lock doesn't work. So you're sort of doing something in an awkward way very frequently. There's increased physical strain with trying to hyperextend your fingers in order to manipulate the instruments. Lara Devgan, who I've known since she was a kid, and now she's an Instagram superstar facial plastic surgeon, has actually designed small, beautiful scissors. She sent me a pair, gorgeous, that don't make me hyperextend my hand to use it. And they really make you feel lovely at the end of the day. So traditionally, instruments were designed by men for men. And if you look at industry reports, they are creating instruments that fit the 5th percentile of hand length for women and up to the 95th percentile of hand length for men. So it's really, really important if you're consulting with an instrument company, you're giving anybody any advice, that you make sure that the people of smaller hand sizes are included in that dialogue. So there's another study looking at about 500 surgeons. 85% were women, and of the full survey, 20% were otolaryngologists. 68% reported trouble using surgical instruments, primarily endoscopes. Look at the size of these endoscopes, and even the needle drivers. Like sometimes the OR tech will hand me a long needle driver, and I'm like, no, I'm in the ear, I need a small one. I'm in the ear, correct, but I actually need a small one because that's what feels the best in my hand. 38% of trainees reported that their hand size not matching with the retractor affected their ability to learn a procedure. We're already nervous enough as trainees, and then when it becomes more and more difficult to even manipulate the instruments, it's quite easy to push us to a side and not teach us. So here you can see different hands using different instruments. I put the Acclarent balloon in the picture at the bottom because they did in fact ask people of various hand sizes to come by and look, and I talked to them about, this is my glove size. What I want to do is I want to be able to hold this part between my second and third finger, and I want to be able to push this daisy wheel with my thumb. And in order to do that, the daisy wheel cannot be more than this length, because if I do this, I can't reach it without affecting the working part of the instrument over here. And I was very glad that they listened, because that instrument actually works, I think, for the 95th percentile for men and women. This is an example of an ear endoscope made by 3NT called Colibri. I don't have any relationship with any of these people other than I like their instruments. And this is so easy and delicate to use in my left hand, where I'm not struggling to make sure I have the screen at the proper height for my eyes, and then I can see what's going on, as can my team. So what happens when you use a microscope? So here's a right ear, and I'm sort of drawn out a perforation that anteroinferiorly is hidden by the anterior bulge of the ear canal. So what is our normal thing? There's a very famous movie called Easy Rider where they ride back in their microscopes. They're super cool, and they're really, at the end of the day, must be super uncomfortable. This is unfortunately a representation of how I look sometimes at the end of the day. So what you don't want is this picture. You don't want to be leaning back like these very cool motorcycle riders. You don't want your neck to be in a funny position. You don't want your arms hyperextended. What you do want is you want to have that right angles. The microscope should be at a good level. Should be able to breathe. I sometimes will say to my residents, if you had a substernal thyroid here, you would actually be dead because your neck is so bizarrely flexed that you can't breathe if something's obstructing your airway. So the line of sight for monitor, I've mentioned a couple of times. It's a funny joke that I found. If you keep hyperextending your neck like that, honey, we'll have to give the chiropractor all your allowance. But really, you don't want to be looking up like this at the monitor. You want that monitor to be directly at your line of sight. And the 1 to 5 seconds that it takes to bring the monitor to that level is really very important. So what about the role for exoscopes and endoscopes when we do heads-up ear surgery? There is a role, and I think that we are developing that role over time, but you could see an exoscope on the left side and an endoscope being used with a microscope available on the right side. And so when we do that, do we harm our patients? Because our first dictum is do no harm. Our first thing when we leave the house and go to work is to take care of our patients with every manner that we can. So what happens when we use a microscope, an exoscope, and an endoscope? And so this study looked and showed that the working distance from the microscope is about 200 to 400 millimeters, as we know. Normally, ear surgeons keep it at about 250 millimeters. Larynx surgeons keep it at about 400 millimeters. An exoscope has a wide working distance. An endoscope has a very narrow working distance. You have to be right up against that structure to be able to see. Your field of view, which should be narrow for the middle ear, is nice and narrow for a microscope. It is not for an exoscope, and it's okay for an endoscope. Your depth of field should also be pretty low, and that can be easily done with a microscope and an endoscope and needs some adjustment with an exoscope. In terms of imaging, you can have 3D imaging with a microscope with the viewer side, not with the assistant side, unless you have a lot of money. Normally, the assistant side is a 2D view. And you can have a 3D exoscope, but the normal exoscopes and the normal endoscopes are two-dimensional. So there is a learning curve to exoscope. There's some repositioning. It's a little counterintuitive, but certainly can be learned. The image quality is pretty good, but not as good as a microscope. You really can, that field of vision is a barrier for transcanal or middle ear cases. And then if you're either wearing 3D glasses for a prolonged time, that can lead to eye strain. Or if you have a 3D monitor where you don't need to wear glasses. I looked at that for the first time at the Harvard endoscopic ear course a couple of years ago. And oh my goodness, that morning, I hadn't slept well. It wasn't my own bed. It was a hotel. I was dehydrated. I had had coffee because the tea in America at hotels is terrible. And I'm not a coffee drinker. And I looked at this for about 3 or 4 minutes, this screen, huge, big 3D screen. And I was like, oh, my sister has migraines, and I'm probably able to develop migraines if I push myself. And so I was like, oh, I can't watch this. Your surgical team comprises of a lot of people who might be migraine prone. So you have to really think about how dehydrated we are in the OR, how we have to take eye breaks, how we have to take care of ourselves, even when we're using something that is clearly designed to help us navigate maybe a more challenging anatomical situation. And then I just want to say, I am so grateful that we're talking about wellness. And one of the things I think is the most important about wellness is being serious and having fun while you're serious. So the left picture is at an American Otologic Society meeting in Austin, Texas, a few years ago that happened to be held on the day of the Kentucky Derby. And Dr. Goseni, myself, Dr. Slattery, Dr. Van Butis, and Dr. Young, we were pretty good sports and we put on some awesome derby hats. So while we were doing something very serious, we remembered that we were friends and we were having fun. And just a couple of weeks ago, Dr. Iyer and his wife came to America and took the time to come by and visit my husband and myself and my children at our home. And this to me makes me well. So thank you guys so much for listening, and I look forward to the rest of the meeting.
Thank you very much, Sujana. That is an excellent talk. Thank you very much. I would say that you've covered quite a lot of things, and some of the things even are new to me. But when you think about it, you're right. The instrument design, and they are not taking into even when you have a left-handed and right-handed trainee, that is another nightmare which happens all the time. And but we have not taken allowances for that at all. So it's a good thing that in future maybe we'll have the time to interact with the instrument makers and make some amends. So the plan is to have the Q&As at a later time so that we can finish early. So I think what I'll do is I'm just going to share my screen. And okay, so the next speaker for the day is Anand Vijendran. He is my colleague, consultant otologist based in hospital in Stevenage. And he's also a council member in the British Society of Otology. He's one of the youngest members in the council. So when I said that, we are going to have this meeting on wellness and ergonomics, I was surprised when Anand contacted the very next day and said that, I have a good interest in ergonomics and can I give a talk? And so he apparently has done a lot of work on ergonomics and back pain and neck pain. So without further delay, I will invite Anand to give his talk. Anand?
Thank you very much, Arun. I am just going to try and share my screen. Tell me if it's sharing, if you can see my talk. Did it come through okay?
Not yet. I will stop sharing and then maybe, yes.
Is that better now? Am I
Yes,
sharing?
excellent.
Perfect, thank you. Thank you very much for the introduction. My name is Anand Vijendran. I'm an otologist based at the Lister Hospital in Stevenage in the UK. And I was going to talk to you guys a little bit on neck and back pain. I'm going to try and build on Dr. Chandrasekhar's great talk and hopefully go through some of the stuff that she said and just sort of confirm that, and then look at ways that we can try and reduce, avoid, and recover from neck and back pain from ear surgery. So work-related musculoskeletal disorders is a common term. It's a group of painful disorders of various muscles, tendons, and nerves in different parts of our body. So is this a problem in our specialty? Well, if you look across the world, there are papers from pretty much every single continent quoting rates of around 46 to 90% of ENT surgeons being affected by work-related musculoskeletal disorders. There is enough evidence to even collate a systematic review and meta-analysis where 2,000 odd surgeons have reported struggling with this. And what was really interesting was that up to 23% of them had taken time off work, and up to 6% had stopped doing the thing that they really liked doing. So who's really affected? Well, we are. Our plastic surgical colleagues are not far behind. General surgeons, neurosurgeons, And you can see there's a little bit of commonality here in terms of the nature of the operating and perhaps the type of the equipment that we use. When we dial down to the subspecialists, to the subspecialties, we seem to be leading the front ahead, with otology being the most affected subspecialty. And when you look at the particular groups of muscles, it seems like the neck, the back, and the shoulders are the ones that are truly at risk. So why are we at risk of this? Well, looking at the literature, there are a few principles that sort of give us the idea behind it. The postures we adopt, the equipment we use, precision and the nature of the work we do, the amount of time we spend doing that work, and a fair few other psychosocial factors. And I'd like to take a little bit of time just to focus on these few elements. So posture. We are relatively infamous in getting ourselves into weird and wonderful postures, particularly when we're trying to do some pretty difficult stuff. Either that's peeling off cholesteatoma of an exposed membranous labyrinth, or a foot plate, or the dehiscent carotid. We tend to get ourselves into weird positions and stay there for prolonged periods. When we flex our neck at particular degrees, that seems to cause an increase in load across our spine. And you can see that every 15 degree of angulation causes a parabolic increase in muscular strain. And that has quite a large effect on the postural load onto our cervical spine. What about when we go into extension? Pretty much the same thing. So the ruler analysis, which stands for rapid upper limb assessment, classifies your neck strain based on grades of 1 to 4. And you can see in the bottom screen here that every angle of cervical flexion increases it by 1 plus 1 plus 2 plus 3, and extension gives it a plus 4. We've got ourselves into positions that there are even terms to describe how we get ourselves in these postures. So what about the equipment? Well, microscopes, as we've discussed, are a common cause of us getting into these sort of positions. We found that microsurgical trainees tend to flex their neck more than 10 degrees 88% of the time. Are endoscopes any different? Our colleagues from Johns Hopkins have found that, yes, potentially there is less neck flexion on average with endoscopes in comparison to microscopes, and certainly less neck extension with the endoscopes as well. Our colleagues from the Mount Sinai in New York found that there is certainly more neck flexion and pain when microscopes are used in more flexion and pain using microscopes compared to endoscopic ear surgery. However, it does come with a few other risks. We are reliant on looking at monitors when we're using endoscopes, and sometimes when they're incorrectly placed, they can encourage static and neck and back posture for prolonged periods. And also, you're relying on marrying up screens, a 2D screen with a 3D live image. And there is an element of disconnect between these two, which can cause further strain. So it's something to be mindful about. The table height also plays a very important role. An optimal table height can reduce it by a large percentage. However, most tables do not seem to be well designed for microscopic or endoscopic work. Philip Chen from Texas had looked at the operating table positions for seated otolaryngology procedures. They took the average American male and female heights to range between 160 centimeters to 190 centimeters, and sort of found that the operating table should be able to get down to about 63 centimeters when measured from floor to table height to try and get an optimal operating position for seated procedures. And they then looked across major operating table providers and producers in America and found that only one of them met that criteria. And certainly the amount of time we spend operating plays a huge role. The vast majority of ear surgery takes between an hour and a half to 4 hours. Acoustic neuroma surgery and arthroscale-based procedures can take longer. And we can find ourselves in static positions without being aware that we're stuck in these positions for quite a while. we looked at the amount of time it took to develop neck and back issues in simulated static procedures, and found that it took an average around 5 minutes to experience neck fatigue, an average of 8 minutes to experience back fatigue, and around 14 minutes to get pain in both sides. Now, I think it's quite unlikely that we would spend 14 minutes fixed in a particular position, but it's not uncommon for us to try and spend 5 or 8 minutes without us being aware. And when we finally get out of those positions, I think the vast majority of us would experience some degree of fatigue in some of our neck and back muscles. So what can we do about these things? Well, I think there are things that we can do even before we start getting scrubbed, the things that we can do before we start operating, the things that we can do while we're operating, and there are a few gadgets and instruments that we can probably adopt in our lives that can make things better. So stretching is very much a concept that's well established in high performance sports. I think it's extremely unlikely that Usain Bolt will get out of his bed, put on his Puma shoes and run the 100 meters without first doing some sort of warm-up exercises. And I think it's probably a concept that should be quite common and familiar to us as otologists before we start operating. There's a vast majority, there's a huge abundance of exercises available on the internet. This is one that was designed by colleagues from the Cleveland Clinic, which encompassed a few generic stretching exercises that surgeons could do just before they start operating. Postures play a huge role, and getting into a comfortable position, as Dr. Chandrasekhar had mentioned, is of vital importance. When we reviewed the risk factors for developing work-related musculoskeletal disorders among surgeons who operate in the head and neck, so these include plastic surgeons, max-fac surgeons, ENT surgeons, and neurosurgeons, we found that the optimal operating position is in a seated position with your neck flexed no more than 25 degrees, the shoulder joints flexed less than 20 degrees, and abducted at about 25 degrees, preferably with armrests. The elbow joints flexed around 60 to 100 degrees, the wrist flexed about less than 15, the hip joints flexed about 90 degrees, the knees about 90 to 130, and the ankle relatively neutral on the floor. And this gives an equal distribution of weight across the entire spine. The table height, ideally, if you're standing, should be 0 to 10 centimeters below elbows. It should be about half the surgeon's height. And if you're seated, based on the reports from our colleagues in Texas, then it should be around 63 centimeters from floor to table height. Rests can play a huge role when supporting your postural muscles. We found that in simulated procedures, when we introduced the rest to support the neck and the back, it certainly increased the time to experience neck pain and fatigue. And it also reduced the muscular activities in those areas when we measured it with EMG. So there's certainly something there that could be adopted and made more widely available. Micropauses are a concept of exercises that a clinician or someone would do every 20 to 30 minutes that last for around 20 to 30 seconds. They're based on the concept that prolonged static positions can cause discomfort, which leads to inflammation, and this impairs healing signal and then causes scar tissues to develop. We designed a very simple micropause technique, and when we tested this out in simulated procedures, we found that muscle activation was certainly reduced in the neck and shoulder muscles by a significant margin, and this was measured with EMG. I had the honor of visiting the Nijmegen neuro-otology team some years ago, and what I found really astonishing was that every 20 minutes or half an hour, a timer would go off in theaters, and the scrub nurses would tap the surgeon's hand and remind them that they need to stand up and move around and stretch their muscles. And this was a practice that was adopted by all the neuro-otologists in Nijmegen, which I thought was quite incredible. And finally, the equipment that we use can play a role. Exoscopes and robots are emerging. Its evidence in ergonomics is not quite established, but I think in time to come, we'll see more papers churned out on how it could hopefully help improve our posture. There are the rocker bottom shoes, which are recommended for people without back injuries. And these have got better distributional gravity forces on the axes, which reduce the impact on spine and feet. And there are a couple of major footwear companies that design them. They cost roughly between 50 to 100 British pounds. Our colleagues in New York had looked at soft collars during otological operations amongst residents and fellows, and what they found was that trainees seem to spend less time in high-risk neck positions when they've got a soft collar on. A collar like this cost about £20 or $26 American dollars on from Amazon Prime, and it's even eligible for Amazon Prime 30-day money-back guarantee. So you're not getting onto it. You can always return it, and they come in various colors. They're quite fashionable. And finally, there's the concept of exoskeleton, which is based on invertebrates and arthropod concepts. They are used to support postural muscles and have a history in sort of spinal injury field. There is a fair bit of evidence in lots of other repetitive strain injury or repetitive task industries like plastering and manufacturing, and there is increasingly some evidence in surgery as well. And I think with the advent of exoscopes and robots and exoskeletons, I think it's, the time may come that we could turn up to work in a shiny suit of armor and be a new front of otologists with better postural control. Now, having all this knowledge is great, but I think the real key here is to try and introduce awareness, to try and bring it as early as possible so that we can try and prevent what seems to be an epidemic of musculoskeletal problems amongst sort of more established otolaryngologists. And one of the things that we are trying hard in the UK is to try and ensure that people coming onto the otology pathway are well versed with these concepts, and introducing it to the residency and training programs could be a way forward. Thank you very much for listening. I will happy to take any questions, or if we're doing questions later on, then I'll pass it back to Arun.
Excellent. Thank you very much. I think, that was a very nice talk and it answers many of the sort of, the areas that we, want to consider how to avoid neck and back strain injuries. And, I wish my nurses will tell me once in 20 minutes, but they tap me once in 20 minutes to say that I have to hurry up and finish the operation. Okay, so I think now what we just going to share my screen and on to the. Okay, so now next item on the agenda is the panel discussion. So I will introduce the rest of the faculty. So we got William Slattery. He is the current president of the American Otological Society and also president of the world famous House Ear Clinic in LA. I had the fortune of visiting the House Clinic just when I started as a consultant, which is an attending in the UK. And that was in 2009. And I spent 1 week there observing, and, what a nice atmosphere you have. And, I was very much welcomed by everybody there, and I learned a lot. So I'm sure that we can tap onto the knowledge of William and get many of his opinion and experiences shared with all of us. And we are also fortunate to have Peter Monksfield. He is the current president of the British Society of Otology, and he's a consultant ENT and skull-base surgeon at the Queen Elizabeth Hospital in Birmingham, and also he's a clinical senior lecturer at the University of Birmingham, and he also has an interest in cochlear implants and other middle ear implants. Right, so, and Martin Stepek is Scotland's leading mindfulness teacher. And I think he writes a weekly column on mindful living in the national newspapers, and he has authored 6 books on the topic of mindfulness. And he's also a poet who has written several volumes of poetry to his credit, and recently has published a book on his father's traumatic experiences in early World War II while they were in Poland. And on top of all this, he does run and advise a busy family business in West of Scotland. So the panel discussion, it's fairly general, and there are not sort of, like I said, they're not very scientific or technical questions. It's more generic questions that I want to discuss. So the first question is, imagine yourself starting your otology career, and imagine you're in a sci-fi movie. I'm sure that Bill will be able to imagine it. He is in Hollywood. And what advice will you give to your younger self? So I'll start off with Bill.
Well, thank you. And the two previous presenters did a wonderful job talking about ergonomics and positioning. And I think, if I may, before I address the question, just make a couple comments, because I think it is so important to think about positioning and hand position. And as I like to think about it, a couple things. One is, Jim Sheehy, who was one of the first members of the House Ear Clinic years ago, back in the 50s, and if you go back through old textbooks, you'll see his picture of how to position yourself in ear surgery. And then, of course, I had the experience of having two of my mentors at House also have back problems. So it's kind of beat into us and ingrained in us of, look at how you're positioning yourself. So the first thing I do with all of our fellows is we spend a lot of time talking about ergonomics. And as I like to think about ergonomics, I think about it in two ways. One is your body position, and then the second is your arm and hand position. And I think too many times people, especially the younger person in the career, you're so focused on what I need to get done with those. Is that facial nerve going to be exposed, or how am I going to approach this ear, that you don't think about, and how am I going to sit in my chair? And I recall very early in my career, I was having shoulder problems. And I one time mentioned to one of my patients, you learn so much from your patients. He was an orthopedic surgeon. And I said, I just have these shoulder problems every night. I just kind of stiff. What's going on? And, he had me do some movements. He said, oh, well, your shoulders are fine. Go see a physical therapist. So I went to the physical therapist, and we sat down and we reviewed, how am I sitting? How am I operating? And what I realized is my chair height was the wrong position. And as soon as I changed my chair height for my body, all of a sudden I had no more shoulder pain, and it all went away. And fortunately, that was many, many years ago. So I think the first thing I would say to the young otologist is you should find a physical therapist and actually seriously sit down with them and have them review, how do you sit, how do you position, even a consult. I was thinking about this as Sujana, you were giving your talk. I think it may be incumbent upon all of us to have our physical therapy colleagues maybe come in while we're in our training programs and actually watch how our trainees are actually sitting and moving or standing, to realize these tiny little changes that can make big differences. And so, as I like to think, Sujana, the picture that you showed and Jim Sheehy showed of, back against the chair, bottom up against the back of the chair, legs at a 90-degree angle, that's your body position. Your head needs to be straight up and down. And then the second thing you need to think about is your hand position and arm position. And I do a little thing that it's not very pretty, but nobody ever forgets. I put my elbows up against my, I don't know if I can show it here, but I put my elbows up against my chest and I dance around like this. I say, I'm a T-Rex. See how this T-Rex works? You've got your elbows, and you're not getting the full effect, but it's pretty ugly. And nobody forgets it. But, T-Rexes had these tiny little arms. And as they say, you have to have your elbows against your chest. Now, obviously, there's differences in men and women of how you can position those elbows there. But the idea is that you want your shoulders relaxed. The shoulders relaxed when your elbows are against your chest, and how you can then get your position up to the microscope or endoscope or whatever it is. And then thinking about making sure the hands are relaxed, whether it's your elbows on the, somewhere. Anyway, I go through this whole thing with all of our fellows, and I think it's something that we have to just kind of indoctrinate in people to get back to, how do we protect ourselves for long-term health? So that's one of the things there. And then, so that's my younger self. I get a physical therapy consult. I did that early, not because I thought about it. It's just because like I said, my patient told me, and that was helpful. From the standpoint of advice for my younger self, it's prioritization of yourself. I remember I went to a seminar that was given back in the late 1980s, and it was winning grants in the 90s, and it was talking about how do you develop yourself as a clinician scientist. And the one person at the talk said, you need to prioritize your time. If your priority is research, take a day a week, 2 days a week, whatever it is of research, and protect that time. And I think the same thing applies here as we're talking about wellness, is when you think about wellness, protect the time, prioritize. I'll never forget, there was one of my patients also who was a wedding planner, and she came in and she says, do you have date nights with your spouse? And I said, what's that? She said, well, it's just a time you take an hour, you go get ice cream, you go for a walk, you go do something that you prioritize your time with your spouse. And I've had date nights ever since. She says, it doesn't have to cost a lot of money, doesn't have to, but you have to prioritize that. So again, I think part of this is prioritizing what is important in your life, whether it's research in your career, whether it's wellness, and all of us need to prioritize wellness and make sure that we prioritize that and take time and protect that time as we move forward. So that would be the main advice I'd give to the young person. So I'll stop there.
Excellent. Thank you, Bill. I'll now ask the same question to Sujana. I'm not implying that you are not young.
I think I will echo 100% what Bill said, except that I know Kelly Slattery very well, and she would appreciate something a little bit more than one scoop of ice cream once in a while. I think absolutely learning to take care of yourself. I think as Anant was talking, my father is an otolaryngologist. He actually is FRCS from Edinburgh. So we're very across the pond based in the beginning of our lives as a family. And I remember, which I hadn't remembered until you spoke, Anant, that my father actually does to this day at 92, 10 Surya Namaskaras or sun salutations every morning before getting in the car and commuting to work and seeing the patients and doing the surgery. And I think at this ripe old age, I've started trying to do that because we are very stiff when we wake up. And I'd like to be Usain Bolt one day, right? So I think it didn't even dawn on me because it's, you don't notice what your parents are doing ever, right? And so I think I wish that when I started this career at 22, I wish back then my body was supple. I could stay up all night. When I wasn't working, I was out at the discos dancing. Nobody needed any sleep. Nobody needed any rest. And then suddenly you need all of that. So I think realizing that it is not selfish, as Bill said, to take time for yourself. It is not selfish, and it in fact helps your patients and their families and your career to take more time for yourself. The one time I did remember that I could take time for myself is when I had to. I have 4 children, and when you become pregnant, I will say that it is extremely invigorating process because you suddenly realize that you have to eat 3 or 4 or maybe 5 times a day. You have to drink the proper drinks. You have to, you just have to be in a proper mind and body space. And you really, really take care of yourself. And I truly have never been healthier than the 4 9-month periods of pregnancy. And maybe afterwards when I was taking care of the children, because I didn't do it for myself, I did it for them. And I think it's quite reasonable to take that for them out of the equation and make sure that you are in fact eating at proper intervals, drinking enough water, getting some stretches and some exercises in, and having the mental health benefits of enjoying what you're doing all the time. And I hadn't remembered that, Bill, that it was actually Dr. Sheehy who talked to us about sitting properly and making our microscope parfocal. And I still tell my trainees, I'm always operating with my pinky out like I'm having tea with the queen. My brain still says queen. I understand it's a king, but I'm always supporting every aspect of myself so that I take the strain off of my neck and shoulders. And I think the more that we talk about that early, the better it is for ourselves in the future.
Okay, that's great. So, Peter, do you have anything to add?
Only to sort of probably echo and say very much the same things that have been said already, really. I mean, sort of thinking back to my younger self and advice that I would have given myself. I mean, the first thing I always think about is my otology career is about my otology career. And so I say you've got to spend lots of time in the OR, you've got to see a lot of operating, you've got to experience surgery. And one of the things I do sort of try and drum into our current trainees is that your training is very much your responsibility as much as your consultant and attending trainers responsibility to train you. You really do have to have some responsibility in your training yourself, but also your lifestyle too. And there was a fantastic inspiring lecture given by Tim Minchin a number of years ago to the graduates of Western Australia, and you can watch his speech on YouTube. He's a guy who is a musician and a comedian from Australia, and one of the things of his points of advice is to exercise. You've got to look after yourself. You've got to look after your body, both from the point of view of your of exercise and nutrition completely. And that's something that is so easy to forget, particularly in busy jobs and spending lots of time working and then on call and time around all those things, is to forget about looking after yourself. So spending time both looking after your body from your physical point of view, but that also has a massive impact psychologically. The other thing I was really interested, William saying about having a physical therapist looking at your body position and someone externally looking at you. That's something that as someone who really enjoys cycling, if you want to have the best power output for your bike, you get someone to look at you and set up your bike and adjust all your positioning to give you the best output. And so, of course, if you're going to spend hours in a position optimally functioning, you want to be in the best position possible. And it's all very well saying, you figure it out yourself, but actually getting someone to come in and look at where you're putting your seat height, the table height, where you are adjusted towards your microscope or your equipment, I think is a really important point. And all of our hospitals have people working there that are in occupational health and physical therapy who have the skills that they should be looking at the employees in the institutions and trying to give advice so that we're optimizing people's position and preventing the problems down the line, rather than only looking at people once they've got a problem. So I think that's a really important point that we should all be thinking about, and going to our hospitals and saying, well, maybe we should be having these individuals going around the ORs and making sure that we're set up correctly and protecting ourselves. I think that's the main advice I would give, I'm sure there's another thing I was going to say that's just slightly escaped to me. I'll come back to it, I'm sure.
We'll go to the next question, Peter, anyway. So, okay, so, okay. So, the next one is, the complications, complaints, and near misses, okay? This all happens to all of us. And, what is the effect on, how do you deal with it and how to sort of move on? So I'll ask you this question, Peter. What do you think about, have you had any experiences either yourself or dealing with somebody who had a major complication? And then, the reason I'm asking is as soon as I started as a consultant, I went to this meeting, Royal Society of Medicine in Otology in London. And I was standing there and the trainee calls and say, oh, by the way, the patient that you operated had a facial weakness. And I was a bit upset. And then, I didn't know whether he was talking about the patient that I just did and, got onto the plane. And then he's saying, by the way, the other patient you did, he's got clear fluid coming out of the ear. And I thought, I'm not going back to Scotland. I might as well disappear. So luckily, my senior head and neck surgery colleague, he called me later on and said, what he meant is the person that you operated 10 days ago has developed a bit of weakness, nothing to do with your surgery. We have taken the dressings off. And the watery discharge, that is a patient well known to him. It is probably the allergy to the packing material. You don't have to worry. Just come back when you're ready. So, this is one of the scariest moments of my life. So, Peter,
Yeah, I mean, there's quite a lot to be said, I think, for navigating this area, because for all of us, if you as much as we think we're infallible, we're all going to have complications. We all counsel patients about the pros and cons of surgery and the things that will go well, but the things that could go wrong. And I think there's a real art to managing this. And there's certain people. One of my mentors when I was starting out was just amazing at having such good relationships with his patients that that there'd been an inevitable complication, and the patient was devastated that had happened, and for the surgeon. So they were upset for the surgeon that they'd had a complication, for him, and it almost felt like completely the wrong way around, that the patient wasn't upset that it had a complication, they were upset for the surgeon. And so having a good relationship with your patients, in that you're obviously communicate well, and that they're aware of what their part of the bargain is, because they're going into surgery with you as a deal. They're part of the deal is that they're going to show up, do all the right things, try and minimize the risks of a post-operative problem, of getting a complication, not immediately blowing the nose and trying to pop your graft off their eardrum that you've just spent hours putting there. So there is a part of the whole contract that the patient needs to take responsibility for, but understand that, not sort of lay all the problems on the patient as it's all your fault you've had a complication. It's very much a joint process. So managing that relationship is the key, really. And so going into it, making sure that you've spoken to the patient yourself. You're not just turned up and the patient's on the table ready for you to operate. So you've met your patient beforehand. They know what they're getting into, and managing the problems afterwards, so that if there is a complication or there is a complaint, that it's met head on, that you recognize that you communicate well with the patients and address that. Don't try and hide from it. Don't try and leave things to stew, or to another day, or to leave weeks on end for things to be addressed. So really try and have a really good relationship with the patient, really good communication, and if there is a complaint, addressing it as soon as possible.
Okay, now a fresh perspective. Martin, how can we achieve, how do we deal with something unexpected happens in our life? What do you have any experience or advice on this?
Well, absolutely. This is one of the classic issues in mindfulness is things happen. Not everything is good. Not everything goes according to plan. And what do you do when things don't go to plan? And from a mindfulness point of view, it's always best to just pause. And I mentioned about micro pauses in surgery. You can micro pause at any time during the day. And one of the classic descriptions of mindfulness is being present. Can you notice how you're responding, how you're reacting? And can you see if that's healthy or unhealthy? Can you see if it's in proportion to what's happened, or is it way out of proportion? And the ability for you to calm your own body, calm your mind, and gain a clarity. So you're almost taking a step back from your own issue. And when you take a step back and you can sense it in its true perspective, then you're much more able to deal with any issue. So I think that's the general thing. Moving on is a different thing. If something really bad happens, whether again it's work-wise or just in your home life, I mean, we all will lose the people we love at some point. So, these things happen. You don't really move on, but can you come to accept, and acceptance is a big word in mindfulness, can you come to accept a new reality, whether it's positive or negative, and then move towards the fact that A, you're still alive, B, you have the beautiful moment that's coming up, and can you actually see life as this beautiful opportunity to experience moments, regardless of what has happened in a particular situation?
Well, if I can say something
Sure.
that was really, I was being very in the moment, and that's really important. Things happen in the operating room, right? The anxiety ratchets up. For example, recently, the facial nerve monitor didn't work properly, and I was very nervous that something had happened. And what happens is, when you're nervous and you're worried that you're hurting somebody, your tone changes, the je ne sais quoi in the room changes. You're not in that beautiful space, that you're not in the groove of operating well, having a team. And you may be short, you may raise your voice, you may put an instrument down fiercely, right? You may do something. And I think it's really important at that time to take that micro break and to say, just a second, and then stop and look away from the microscope, look directly at your team and say, I'm really sorry. I was very stressed out. Thank you so much for helping me through that. I think it's going to be fine, right? I think that's really important. It's important for you to say it out loud so that you yourself hear it and your team hears it. And I think there's an advantage to working with this same or similar group of people all the time, because they know you and they know that even if you're a whirling dervish for a moment, you're going to calm down and you're going to break that. You're going to stop that negative energy and bring the positive energy back. So I think that's really, really important in the moment, because otherwise you'll go out, you won't do the right thing for the patient or your team or your trainee. And then the other thing I wanted to say, when Bill and I were fellows at the House Group back in '93, Howard House, because all this concept, everybody thinks wellness and ergonomics and everything is new. It's not new. We're just giving it good names that we can focus on now. But Dr. Howard took us all upstairs I don't know if you remember this, Bill, because you interacted with him so much more over the years, but he said, this is what happens when a complication occurs. What you want to do, because we're all perfectionists, we want to run away, right? We don't want to see that patient. We don't want to face that complication. It's horrible. It hurts our heart every time we think about that person, right? Every time we think about that move that we made in the operating room. And he said, no, this is the person you embrace. This is the person you talk to and you sit down and you spend time with them, as much time as they and their family need. And you see them every single day and you make sure that they understand how much you care. So I think, Peter, your concept of like, make sure you have that relationship with the patient and their family is really important, and acknowledge your humanity to each other. You know, you were saying, Peter, that a lady came in and felt bad for the surgeon that he had a complication. Dr. Howard told us the story of how during an awake stapedectomy, the right angle hook or something broke inside the ear, and the patient heard the hullabaloo about the hook breaking. And, you know, I can't tell you my imagination for what the outcome would be in the litigious United States of America should a patient know that an instrument broke inside their ear. But, you know, the piece was fished out, the surgery was done, everything was fine. At the first postoperative visit, Dr. Howard said, well, you know, the surgery went well, this happened. She said, yes, I'm aware. And she takes out her checkbook because she would like to pay for the instrument that her ear broke. So magic can happen.
So, Bill, do you have anything to say?
I think Sujana, exactly what I was going to bring up, and that is, you know, recognize that when you say, how do you deal with complications and move on? The patient is also dealing with complication and has to move on. And so again, as she just said, this is what I was going to bring up. Your initial instinct is run away, but the idea is you want to go closer to that patient and become more friendly with that patient, in the sense that you're both on a journey. You know, you did something and it didn't go right. That person's dealing with whatever, you know, you did. There's the guilt and everything else. And how did I do this? What should I have done differently? But the patient's dealing with it too. And so by getting closer to them, I do think that helps you move on, as opposed to wondering how is that person doing and being fearful of contacting them. You know, this is a journey that you're, you know, when you have that patient physician relationship, it's a journey you're both on together, and you have to grow closer, as Sujana brought up. So it's embedded in my mind as well, that, you know, because the initial human instinct is to just run away and not see them, but run back to them and get closer.
Excellent. So in the interest of time, I'll have only one more question. That is, career breaks are sometimes inevitable, you know, usually maternity leave, research opportunities, or even, you know, illnesses and other things, things. And, you know, I always wonder, you know, even if I'm going on 2-week away these days, when I get back, you know, I feel that the skills have gone down a little bit. So what challenges are there when you return, and how would you reduce the impact? And I'm going to ask that question to Sujana. I'm sure that she has, you know, quite a lot of experience in this.
Yeah. So as I mentioned, I've had 4 career breaks of about 3 months for the first 3 and about 8 weeks for the last one. And the development of that career break is quite visible to everybody as your pregnancy progresses. People used to ask me, I have very large children, and I look quite pregnant. There's no way to hide it when I'm pregnant. And people would say, "Oh, are you still going to be able to reach the ear? Are you still going to reach the patient when you're, you know, in your 8th or 9th month?" And I'm like, well, I kind of look like some of my professors right now, and that they can reach the table. So So, and if you drop a piston and you happen to have a shelf of a child, it actually catches the piston quite well, and you could just kind of use that. But then you're off, and I was so afraid, especially in my first pregnancy, my first maternity leave, that my entire skill set would be eroded and I wouldn't know anything, and that my patients would all leave. Like, why would they wait? They could go see somebody else. And it was actually when my oldest son was 6 weeks old, my mother and I flew across back to the House Institute. Antonio de la Cruz had invited me to be the speaker at the temporal bone course. And my mother was joking, and I took my mother because somebody had to watch this baby. And my mother was joking with me on the plane. What are you going to teach them how to do? Change a diaper? Because what do I know at 6 weeks of when your brain has turned to mush? And I have to say, with great gratitude, the fact that my professors and my colleagues still believed in me, the fact that we have a skill set that it is very difficult to remove from us. I suppose it's like riding a bicycle again. You just get back on and you get back a little bit slowly. And maybe the first couple of cases you book for a little bit longer than you might otherwise. But, like Peter was saying, the first thing you think about, we're an otologist. We do otology. And so I think that's ingrained in us. And I think a planned break and a planned return can be very, very helpful. An unplanned break, particularly for something bad, is to me a little bit more difficult to come back from. And I think unfortunately, there are situations where women, whether they're the physician or the staff, have had a pregnancy that has unfortunately not resulted in a healthy baby afterwards, or a live baby sometimes afterwards. And I think that's very difficult, because when you do come back from those breaks, every first encounter is, how's the baby? How's the baby? How's the baby? And even when the baby is nice and healthy, it just takes a lot of time. And you're like, okay, the baby's fine. Can I just see you so that I can get back to the baby at the end of the day? But if something untoward has happened, I think that's, reopens a wound for people. So I think it's really helpful if your community around you, when you come back, can help ease that pain if it's a painful break.
Okay. I think there's been a very useful discussion, but in the interest of time, I think I will have to move on. I had few questions more, but obviously we have done so much of in detail discussion. So I think we will move on to the next talk. So I would like to invite Martin to deliver his talk on the theory and practice of mindfulness. Martin lives just about 2 miles away from my house, but I haven't met him yet. We only met through, in fact, today is the first time I'm, actually seeing him directly. We have spoken to him, but my wife has seen him talking about mindfulness. For those of you who haven't heard much about mindfulness, it is a type of meditation without any religious connotations. And surprisingly, many of the principles of mindfulness were developed not in some Far Eastern country, but in Scotland. In Samye Ling is a monastery which is on the border with England, and it's a Tibetan monastery in Scotland, which has been pivotal in developing some of the principles of mindfulness. Martin, correct me wrong if I am wrong, but I'm sure that he will be able to tell you more. But when I spoke to Martin for the first time, I connected him with him immediately, and then I realized that both of our paths about mindfulness started in the same way. During the times of some difficulty, we were looking for some answers, and the first book I saw, which helped me, was this book called Art of Happiness, written by, it's an interview of Dalai Lama by a psychiatrist from the US. And interestingly, Martin told me that the same thing. He started off his experience in mindfulness with the same book. So without further delay, I will invite Martin to give a talk on mindfulness and also a practical session.
Thank you so much, Arun. And firstly, I would like to say how honoured I am to be part of this grouping. One of the beauties of mindfulness is it teaches you gratitude. Grateful to be alive, and I owe so much to medical surgeons. My wife almost died in the maternity ward giving birth to her first son. My son almost died, and if it wasn't for the expertise and the care and the compassion of those people caring for him, I don't know where it would be. Same goes for when my parents were declining. They died 3 weeks apart, and the quality of care, humane care, and the quality of technical expertise was superb, and I will never forget that. And so I think if you take nothing else from this talk, take away the fact that you do wonderful work, and you should feel elated about that. All that said, the emotional part going away, mindful, you are all mindful. The question is, what are we mindful of? Being mindful is just being aware. And it's been mentioned, and Anne's mentioned it as a word, we need awareness. Now, you couldn't do your jobs as surgeons if you weren't aware. You have to be aware of fine details. The problem is, for most of us, we forget to be aware of the other bits that are important in our lives. Our mental well-being, which essentially means, how do you feel at any given time through any given day? So it's a moment by moment awareness. And that also ties in with what the two speakers, the first two speakers, were talking about as well. Physical awareness of how are you feeling physically, because we know we can relax the muscles. We know we can let go of some of that neck issue at the time by repositioning our posture. So mindfulness is essentially the development of a part of the brain, the prefrontal cortex, neocortex, and related areas, which are about a calmer, if you like, wiser observation of what's going on. Whereas what tends to run our lives, and Susanna said, sort of described it really well with the sort of reaction to something going wrong. A part of the brain can see the other part of the brain at work, and you can develop this quality, this skill of calm observation, and mindfulness is the development of that in essence. Can we notice our overreactions on a moment-by-moment basis? Can we, from a result of noticing that, do a little technique to not suppress an unhelpful emotion like anger or fear or aggression, but actually just to be with it, and then to accept it, and then to take the mind somewhere else? It's a bit like if it's raining. This is Scotland, we always get rain. So if it's raining and you're outside, the mind goes, oh, swear word, swear word, swear word, it's raining again. But the calm mind can say, well, let's just go indoors. So this is about self-management, essentially, of our mind. The ancient practices that it came from originated 2,500 years ago, and this person called the Buddha, which just means somebody who's awake, and that was a really good title. He said, I have awoken to the reality of how can I find peace of mind in the world, and how can I help other people do it? Now, that's a very secular interpretation, but that's how I think he was thinking. Now, what he was saying was, it's inevitable that people suffer. It's inevitable that people struggle. And you've explored examples of that in your talks and in your answers to the questions that have been raised. Now, if you can notice it, you can change the scenario, you can change the narrative. Now, imagine it within an operating theatre. I've only been in one operating theatre as the patient in my life, thankfully. But this notion of the physical tiredness. The physical tiredness has an effect on the quality of your work. It can't not have an effect because the body and the mind are starting to feel uncomfortable. Can you, as an Anth described, I'd never heard that phrase before, the sort of the micro pause within an operating sense, but I do micro pauses all through the day. The average human being gets a little bit tired, so a drop in energy levels between every 20 and 90 minutes, depending on the individual. So your day is up feeling good, whoa, feeling a bit down, up feeling good, whoa, feeling a bit down. And if you don't do something about the feeling down bit, you work through the tiredness and you deplete your energy even more and more. So in terms of micro pauses, in terms of mindfulness, you can just notice I'm tired. Now, what I do probably about 20 times a day, if I'm on my own, I'll just close my eyes. That's a single breath in and a single breath out. When the in-breath is happening, I'm saying, the fresh air is blowing away my tiredness. And you can feel your mind emptying. You can do it eyes open and get the similar effect, but the depth of the effect is better with the eyes closed because it's the focus is there. And when you breathe out, think, that's better, I feel peaceful again. So the tiredness is gone. I do the same every time I'm irritated. So if something annoys you, you get an email or you get a cancelled meeting or something like that, and the mind and the body goes, oh, for goodness sake, or worse. So you notice that. You don't suppress it. I just close my eyes again. Breathing in, let it go. It's not that important in the big scheme of things. Fresh air's blowing it away. Breathing out, that's better. Feel at peace. Okay, let's get back on with stuff. Now, this is so simple, but so hard to do because we have to train the mind to remember to do it. It's easy to do if you remember to do it, but if you don't remember to do it, then you get tired or you get more irritated, you get more down or whatever. I was looking at some of the stats on not particularly your profession, but surgeons generally. 30% burnout, anxiety 20 to 50%, depression 24%. People don't get these negative mental states through luck or chance. It's about how we live our lives, what we do moment by moment by moment. And if we can manage moment by moment by moment, then we can prevent the accumulation that leads to these unfortunate states of mind. What we call meditation is a really, really bad translation of two wonderful words, both from Pali, then further into Sanskrit. But the words of vipassana, and vipassana means to have insights. And the other one is bhavana, and bhavana means to cultivate your mind. And what they mean by cultivating the mind is cultivate the best qualities of who you are and learn to let go and manage the worst qualities of who we are. And so this is what mindfulness is. It's you gain insights about yourself and about others through clear, calm observation. And you gain insights about yourself through that. And you also slowly but surely develop continually the quality of your mind. So I've been doing it for 25 years, and probably 25 years is considered a good apprenticeship in this because it's a lifelong practice. And so it's here in Scotland, it's 5:30, 17:30. I've probably done about 10 micro ones. I've done 2 big ones, as in classic meditation, sitting down. By big ones, I mean 15, 20 minutes, that sort of thing. First thing in the morning, I do it because I understand the results. This is swimming against the tide. The tide of the mind is to be reactive. And what we're trying to do is overcome that with a clarity and a calmness, moving on and on and on. The more you practice, the more you push against the tide going the other way. The moment you stop, the tide takes you back to being reactive. And so we have this need to just continue in a very gentle way, very nuanced way, very subtle way, to just gently, continually push ourselves in the direction of best qualities of mind are developing, worst qualities of mind are receding. So that's what the practice is. We'll do a short practice if we get time, 5 minutes, aren't you? So just, oh, one last thing before I go. If anybody's skeptical about that, good. You should be skeptical about things because you should look for the evidence. Cynical is a different matter. Cynical is when people stop believing anything, regardless of evidence. And that's a sign of despair. But you want to know the evidence. Google mindfulness, Oxford University. Google mindfulness, Harvard. Google mindfulness, Stanford. Google mindfulness, all the top 100 universities, and you'll see the research there. And some of it is beautiful to observe because it's about helping people prevent themselves from suicide, from depression, from long-term anxiety. I've done this in every prison in Scotland, and you see the results of what damaged lives can be like. And I've done it for most of the victims groups in Scotland, so you see it from the other side as well. So this is about us nurturing who we are, who we can be. So just gently close your eyes. And for the first few seconds, do nothing. Just rest. You deserve rest. Try not to think about anything in particular. But if thoughts turn up, or moods, or feelings, just be aware of them. And just be aware that you didn't choose them. Thoughts appear to the mind, produced by the mind, without our consent, without our awareness at times. So do emotions. So just notice anything that turns up. And if nothing turns up, then your mind is empty, and an empty mind feels peaceful. And therefore just rest into the peaceful nature of the mind. Now gently take the attention to inside the nostrils, just inside the nostrils. And it's not so much noticing the breath as allowing the awareness to flow in with the air. It's almost as if your awareness becomes the breath, in and out. Just gently, slowly, allowing your body to control the breath. So you're not trying to make it fast or long or slow or quick. Let the body do that. Your attention is on the sensations caused at the ends of the nerves inside the nostrils. And the in-breath feels fresh and clear, and it empties the mind. And the out-breath feels quiet, feels peaceful. So now you have two enjoyable, pleasant tools, if you like, inside your body every moment of every day that you can turn to. An in-breath refreshes the mind. Back to square one, resets it. The out-breath calms you, makes you feel at peace again. So you're clear-minded and you're at peace. And that's the highest quality of mind that anyone can have for any task, let alone the quality and complexity of the work you do. So just on your own, just for a minute, following the breath. And if your mind wanders, don't worry about that. Just accept it. Then pause the distraction. Take your attention back to the breath. Now take your attention up to your eyelids and notice how peaceful they are closed over the eyes. Just rest your attention there for a few seconds and feel the sense of peace that they cause for the eyes. It's almost as if you can breathe in a little bit of the peace from the eyelids. And now, giving them a minute or so, allow your eyelids to very softly and very, very slowly begin to open. As they do so, keep your eyes downward gazed and unfocused. It'll help protect you from the brightness of your screen or your room. Trust your eyes to do this in their own time, in their own way, so don't try and control it or direct it. Let it just happen naturally. And while it's happening, if your mind is quiet and peaceful, just enjoy that. Let it linger until your eyes slowly reopen and return to normal. Just take your time. Okay. Now, obviously, I can't see everyone, but so some will be eyes closed, eyes open. But I hope you found that useful and interesting. Thank you. Over to you, Arun. You're still on mute. I'm mindful enough to notice that.
Yes. Thank you very much for the lovely demonstration, 5-minute demonstration. The first time I did was inside the hospital, when in Wishaw, when the chaplain, he's also trained in mindfulness. I just couldn't believe what a transformation I had within that 5 minutes. I felt that I was almost falling asleep, and then I was worried that I'm going to snore. Luckily, it didn't happen. But the other thing is that you told me that you have written some e-books on mindfulness, and you may be able to share with the participants. Are you still happy to do that?
Yes, absolutely. I'll forward them to you, and you can distribute them the way you best feel suits Arun.
Okay. Thank you very much, Martin. Thanks a lot for sharing your expertise.
My pleasure.
I think now we are coming to the last phase, and I'll just see whether there is any questions in the chat. So I just want to ask the audience, if you have any questions, that the best way of putting them on is in the chat. And if there's no questions, that is fine. But I know that we had a very in-depth discussion about various aspects, and I think that I find hopefully I find that everybody will take the lessons home and practice some of the mindfulness and all the other aspects of the surgical as well as non-surgical aspects of wellness. So
I just say something, Arun? Quite often when you come out of a mindfulness session, and that was a very short one because of the time, the last thing you want to do is have your brain thinking, oh, what questions I want to ask. So there can be just a little lapse period there.
Yes. We'll give them a few minutes. So meanwhile, I'll ask the rest of the panel. Do you have any questions to Martin? As maybe Anand?
Actually, yeah, I did want to ask something to Martin. I remember reading Eckhart Tolle's book a couple of years ago on the New Earth, and I don't know whether you've come across that, Martin, but he talks about the ego and how the ego is like a part of yourself, which is not yourself, but it's a manifestation of a lot of things that you feel and do and think. And that's a very separate entity to yourself. And I find that a useful concept, going back to one of Arun's initial questions about what you do when you have a complication or when you have a panic moment in theaters or in clinic. You've seen something that you are shocked by, and going to these things where I escape for a while, go to the loo, just calm myself down, have a moment to pause and think. try and do some breathing exercises. I do a fair bit of Wim Hof breathings, and I find that quite helpful.
Yes,
Grounds me.
Sorry, Anant, you froze there and I thought you'd finished.
No, sorry. I kind of finished, and I just said that I sort of do Wim Hof breathings that ground me, and I find that these few concepts very useful in sort of emotionally tensed panic situations, just to sort of.
Yeah, I'll answer that because you froze again though. I think that I like to think, well, firstly, the concept of the self and our consciousness is one of the big questions in science. It's so, where is the self? What is the self? I like to think from a practical point of view that there are multiple versions of me in a healthy observational way. So the angry me is not the same as the calm me, and the tired me is not the same as the active me, and the fun me is not the same as the reflective me. And the me that's listening to rock music is not the same as the me that's listening to classical music. So we have multiple versions of ourselves. And the question is, what's the appropriate person to be me in a particular moment? And I think that's, your point about, when you're tense and when you're worried about something and maybe in theatre, is can you replace that worried, tense person with the calm, clear person and get to be comfortable? There's a beautiful teacher, sadly died a few years ago, Thich Nhat Hanh, who was a Vietnamese Buddhist monk. He brought mindfulness to the West, essentially. And he used to say, love all the versions of yourself. Love your angry self, love your annoyed self. So don't fight them, don't think of them as the enemy, but do replace them from time to time with somebody better. I hope that maybe helps a little bit.
Yes, thank you.
Anybody, any other of the panelists, any questions? Sujana, do you want to ask him anything?
Or an observation.
I have so many things to ask, but that we do actually have a question in the Q&A.
Yes.
Bhav Patel says, thank you for a terrific session. His question is regarding prehabilitation. I agree with the value of stretching prior to surgery. Does the panel have any suggestions on specific exercising, strength conditioning, etc., that can make you more resilient? Maybe Anant knows?
Thanks, Bhav. So I don't know of any specific routine, I have to say, but I think any form of strengthening exercises, anything that improves your core muscle strength, whether that's Pilates or bar or some sort of high sort of speed yoga, or even sort of sports, would probably carry a degree of benefit to your postural muscle control in surgery. I think it's sort of cross-relational in some ways. So I don't have a specific routine, but I think something is better than nothing is what I'll say. I don't know if anyone else has any specific advice or guidance on that.
I'm happy that you mentioned the core muscle exercises. The main problems all seems to be in the midline, okay, the neck and the back, and that's the usual self. A few years ago, I was doing some repairs at home, and I'm an enthusiast of doing it yourself. But I think probably I overdid it during Christmas time. And then what you have to realize is that these days, when we get older, the repair and the recovery is not as fast as when you're young. So this is informed to me by the orthopedic surgeon and the physio team. So the shoulder muscle injury or the stretch, it caused a lot of issues. And then I realized that actually the core muscle exercise is the best thing to do. And so the thing that I try to do, I've been doing it for the last 10 years, is a lot of sit-ups so that the anterior core muscles are strengthened. And then there are exercises where you can stretch and extend your back. And there are specific equipment in the gym which will let you do that. So that will also help. But that will strengthen the core muscles and the paraspinal muscles and the neck muscles, and that will be helpful. And the other thing to remember is that if you do endoscopic ear surgery like me, the left hand is going to be sore. Every Monday, I used to have left-sided chest pain radiating to the arm. And what do the doctors think? That's it, you're finished, isn't it? But when you go to the gym or run, nothing happens. So I told my wife that I am having this, but she's a family medicine specialist and she's got better sense than me. And then immediately said, every Monday it happens, isn't it? It's something to do with your work. So absolutely. So, after that, I looked at my setup and, appropriate arm support and everything. But the main thing to remember, there are three things as we get older, or if you want to keep your body in fit shape, that is the strength training, so that the muscles and the bones will be okay. And then you have the cardiovascular exercise to keep your cardiovascular health, like running or Pilates and all those fast activities. But one thing that we all forget is the balance exercise. The balance. Tai Chi and other type of balance exercises are very important, because if you do these three things, if you're going to the gym, there's no point in doing only the cardiovascular, only the weight pumping exercise. It should be a combination of these three things, so that your core muscle strength will be appropriate up to a limit. I started doing all this because my parents probably they passed away very early, and they were not in the habit of doing any of these things. So it helps up to a limit anyway. So there are three aspects to well-being, as we all know. It's the body that we have talked about it, the mind, and intellectually we have to think about where do you want to go, and what do you want to achieve in a few years' time, and where your career and life itself is going. So that's what I would say. So core muscle exercises will help up to a limit. It may not avoid it fully. Nothing can compensate for a bad posture, but at least it will help you to alleviate the symptoms up to a limit. So let me
Can I just throw in something, Arun, just on that? Somebody mentioned resilience. I think it was Sujana. In mindfulness, we have a philosophy of resilience that is slightly different from the normal definition of the word, which is the ability to bounce back. With resilience in mindfulness, you want to try to build as much of the positive, like you just described in terms of physical well-being, but also mental well-being, so that when the inevitable difficulties happen in life, you've got such a bank of strength, physical and mental, that you're better able to handle it, and it's easier to recover from it. So the philosophy, if you like, or the practical implication is keep pushing those physical and mental well-being sides up, because things will happen and you will be able to handle it better. And just as a complete aside, I'm left-handed. The world is against left-handers, so goodness knows how you guys do it in operating theatre with it. And
so I think you're right. I think it's a bank that always has to be refilled. And we counsel ourselves, and we counsel our trainees, and if we're lucky enough to have children, we counsel our children, but we counsel our patients. And tinnitus, which is ringing in the ears. One of the I had the opportunity to work on the American Academy of Otolaryngology clinical practice guideline, and one of the things we recommended is cognitive behavioral therapy. And I thought, oh my goodness, we're finding this data. Now I have to go back and tell these people who've been told that they're crazy by everybody else, now you're crazy, go get some CBT. But the reality is patients are so willing to have evidence-based counseling and to say, you know what, the cognitive behavioral therapy gives you a chance to practice that mindfulness actively, to say, what is it that's making me nuts? And how do I stop acting nuts in reaction to that? And then how do I remove the power from that? That's a very simple and very non-Martin way of describing this. But that concept really sets the tone, because now they're you know, ear, nose, and throat surgeon, somebody who's, you know, in scrubs half the time, is also talking about mindfulness. And in the talking of mindfulness, it reminds me to think about being mindful when I go home. And I just want to point out, Norma de Oliveira Penido is watching from Brazil, and thanks you very much, British Society of Otology, for putting this very interesting piece together. But Martin, maybe you can help us know the words to counsel our patients as they go through chronic conditions to help themselves.
Well, I guess, first of all, boa tarde to the person in Brazil. Beautiful language, Portuguese. Yeah, I think the first and foremost thing is understanding. If you understand that the mind goes awry from time to time, you know, as you say, that you go crazy. Everyone goes crazy at times. Everyone has a mind that is in a place where you would rather not have chosen it to be at times. And if you accept that, then your foundation is strong. Your foundation is real. This happens. So you're not hammered as much by the reality of it happening as if you'd actually understood that this is going to happen. At some point in our lives, we will lose people we love. At some point in our lives, terrible decisions will happen that affect us, whether it's political, global, or local, or family. And if you take that not as a depressing view of life, but as just a starting point, and then say, right, from that, how do we manage to be happy? How do we manage, as you said, you know, with the two photographs you put up at the end of your presentation, how do you still get joy? How do you still get fun? How do you still love company and love nature and love everything around you? If people understand that, then when these difficult things happen, and maybe from a surgeon's and a medical point of view, if you're able to then present this to the people with sensitivity and maybe even have sort of an A5 flyer or leaflet that describes this, you know, describes the reality of difficulties and the need to work through them and the need to be gentle with yourself when you're hurting. Be kind to yourself when you're trying to come to terms with something very, very painful, physical or mental, but still see that there is a method by which you can manage these things. And that importance of the present moment, you know, being present can't be overstated. You know, in a moment you can feel horrendous grief, but in the next moment you can think, yeah, but I loved that person. And that can put a smile on your face. And it's the method by which we not subdue or suppress the difficult reactions that we have, but actually accept them and then see them from a different light. Or the fact that you look out the window and you think, okay, I've lost somebody, but it's still a beautiful day out there. It's still good to be alive. And that's hard work, but it's doable. And it's doable in little things like my voice is drying up, so the beauty of a sip of water and the gratitude that we've got water. You call it a faucet, I think. You get a tap and you turn it on and the water's pure. This is something we should be dancing in the street about. Dancing in the street, even if we have lost somebody we love, or even if we're going through something very difficult. We have this, and mindfulness helps us bring the fullest reality to us so that we see things in perspective. I've do this a lot. I lost a brother earlier this year. I lost a brother and a sister 4 years ago, and I lost my parents 3 weeks apart just over a decade ago. But you can still be happy within those contexts. But it is hard work because you're trying to train your mind to be what the mind isn't normally like. That helps a little.
Thank you, Martin. And, you know, the Scottish water, you know, I don't mean in any different way. It's very nice and sweet. So much so that
Beautiful.
my son, who's moved to London. And he used to take water home when he went back to the university. Now he's in California, and I'm sure that he's going to miss the pure Scottish water. Maybe because of all the rain. As you say, it's raining quite a lot, but we have water. So I think now we are nearly 6 o'clock, and I'm glad that all the faculty has spent their Saturday with us and helping us with all the interesting questions. So just to wrap up, I'll start off by asking any comments or questions from any of the faculty. Peter, do you have anything to say before we wrap up?
The only thing I was going to make comment on the previous question about some sort of workout regime. I mean, we didn't get onto the subject of social media, but it strikes me as maybe we're absolutely ripe to do a YouTube video of a workout, a preoperative workout for an otologist with the huddle with the theatre team, get everyone doing a sort of stretching exercises. That might be the thing to do. And then with the wrap up at the end of the day, when we all sit around and say everything that's gone well and it's gone bad, and all the positives and negatives, have a sort of mindfulness few minutes about all the positives of the day. Maybe we should be focusing on that around our theatre. But that's just a few thoughts.
Very good suggestion. Now, Sujana, do you have anything more to say before we wrap up?
I think that's a fantastic idea. I think expressing gratitude at the end of your day to your team for a job well done is really, really helpful. I had a visiting person in the operating room with me the other day, and we started at 7:30 in the morning, and when we concluded about 8 p.m., he turned to me and he said, "Why do you have the same level of energy now that you did 12 hours ago?" And I think the answer is you find the joy. I think it's what Martin talked about. Find the joy, find the gratitude. The people around me really helped. The patients did well. That's a good day's work. That's a great day's work. And I think that sets you up for going home and being a full person when you get home. Because I think what Bill was saying about making a date night, making sure that the people we love are not left out of the equation because we're so busy, using up all our resources at work.
I see a comment from Ramesh Rohiwal from India. He says that his professor, PG Vishwanathan, is a good surgeon that I have seen before, said that God has given us only one spine and a lot of patients, so look after your one and only spine, which may be a very good point to remember. Okay, so now, Bill, anything more to add?
I'd like to pick up on something, Peter. You challenged me in one of your comments about, I'm a bike rider as well, but we buy a very nice bike. We go to the bike shop, the bike person sits you on the bike and they fit you for your bicycle. And it's just interesting how much expertise is there to make sure that you sit on the bicycle and are properly positioned. And yet we don't do the same thing when we're actually taking young surgeons and fitting them for their chair and their microscope and all of that, which I thought, wow, that's an interesting analogy, and really appreciate that. Then just one more comment about positioning. One of the things I do all the time with our fellows is I have the nurse take a position of them sitting in their chair. And we're talking about having other people look at us. Picture paints 1,000 words. Having that picture of your posture is actually a good thing. And so it helps, I think, the people learn a little bit better. And then one last comment about mentoring and complications. I'll never forget, as a resident, I had a patient who passed away from a carotid blowout. It wasn't a complication per se of surgery. But I'll never forget my mentor calling me at that night, knowing that I had a hard day, and just actually expressing empathy to me about the emotional aspect of what I was going through. And I think so some of us in the senior categories need to, just acknowledge that a simple phone call, a text, something like that to your trainees really does go a long way. So great session, Arun. Thank you for putting it together. It was wonderful.
Thank you. And anybody else that Anand, do you so I don't think there's any more comments. There's one more question that I've seen. No, I think that's all. So thank you very much for everybody to attend this session on a Saturday. And I've recorded it, and I'm trying to put it up on the website of AOS, and then we are trying to have our own YouTube channel in the BSO as well. Thank you very much.
Great job.
Thank you.
Thank you. Lovely to meet you all. Take care. Keep well.
Thank you. Thank you so
Thank
much.
you very much. Have a good evening. Bye-bye.
Hey guys, stay on for 1 second and smile at the camera. Let me see if I can take a picture. 1 second. All right, everybody look at the camera and smile. Oh, that's really nice.
Okay, you got the picture.
Okay, perfect. Yes.
Thank you, Sajana. I'll see you soon.
Thank you, everybody. Have a great day.
Thank you.
Take care,
Bye-bye.
everyone. Thanks. And thanks, Arun.
Bye.
Bye.
Okay, bye.